All right. Thank you all for sticking with us tonight. I know it's getting late, and I will keep this exciting and interesting for you here. The last segment of tonight's conversation we're going to discuss the nuts and bolts of using cannabis in the clinical setting, and I'll make this accessible to any clinicians that are left in the audience, and of course, the rest of you who may want to use cannabis for yourself or spread this information to your loved ones. As I mentioned earlier, I have a lot of information for patients to learn how to use cannabis most effectively on my website, healer.com, which is free. And I'm really into empowering patients. I think that the clinicians have a real role in healthcare, but patients also have to be enabled to take care of themselves, and cannabis is such an excellent tool for them to do so. So there's a lot of questions often about how strong is the evidence for cannabis in treating certain clinical conditions. Is this all anecdotal evidence? Is just patient reports? Or do we have real randomized controlled trials that are gold standard? And I think you've seen that to some extent throughout the evening tonight, mentions of various trials that do meet that gold standard. Well, just last month, the National Academy of Sciences, Engineering, and Medicine, the Division of Health and Medicine of the United States federal government, released yet another federally sponsored report on cannabis, a 440-page summary of the health effects of cannabis. And they very clearly detail that there is conclusive or substantial evidence that cannabis or its components are effective treatments for chronic pain, chemotherapy-induced nausea and vomiting, and multiple sclerosis spasticity. This is the highest quality level of evidence, more evidence than we have for actually a lot of approved pharmaceutical drugs. They also concluded that there's moderate evidence that cannabis can be effective for sleep disturbances associated with sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. Now, there was also some limited evidence that cannabis can help with weight loss associated with HIV and AIDS. Clinician-measured multiple sclerosis spasticity, the symptoms of Tourette's syndrome, anxiety disorders, and post-traumatic stress disorder, and also some limited evidence that cannabis can relate to a better outcome in the unfortunate circumstance of a traumatic brain injury or an intracranial hemorrhage. So all of these do have some positive evidence, and they deserve further research. Now that's the United States federal government, again, admitting that there's such great evidence for cannabis use in all these different conditions. And of course, in my clinical setting, on the front lines of cannabis medicine, we use it for all of these conditions and several more. So let's talk first about medical cannabis and the treatment of chronic pain. This was a study from 2015 that looked at smoked cannabis for chronic pain. Now, again, as Dr. Russo mentioned, smoking cannabis is often not the best strategy for painful conditions because it has a rapid onset and then it wears off rather quickly. And when patients do smoke cannabis to treat pain, they end up chasing the symptoms. They wait till the pain returns before administering the next dose of cannabis, and that return of pain tends to be a stressful event, both psychologically and physiologically. It's much better to use a longer-acting preparation of cannabis to keep the pain under control. And we'll talk about strategies to do that at the end of the lecture. But this was a safety study. They followed 215 patients that were smoking cannabis, and what they found that the adverse effects or side effects were mild to moderate. You can see them on the slide: headache, irritation of the nose or the throat, nausea, feeling tired and dizzy. But what they did find was that the cannabis group had improvements in pain, so decrease in pain, improvement in quality of life, decrease in symptom distress and total mood disturbance. They did not have any impairment in their neurocognitive function. So this is, of course, one of the myths of cannabis, is that if you use it, it might help with your symptoms, but it's going to make you stupid and slow. That obviously wasn't the case in these patients, and it's been well demonstrated that adults who are heavy long-term users of cannabis, if they stop for a month, or usually if they stop for even less time, their cognitive function, if it was at all impaired, will return to baseline. But importantly, there was no impact on their liver, their kidneys, their blood, their endocrine system, and so forth. Now, there's been a number of trials on neuropathic pain using cannabis and cannabinoid compounds. Neuropathic pain is well known in the clinic as the most difficult type of pain to treat, and Dr. Russo was describing some of it. It can be just exquisite, and what would normally be a light touch that's a non-painful event for most people can be extraordinarily painful for people with some of these conditions. And I'm just showing you that there have been many studies that have shown cannabinoids have been effective in neuropathic pain. Here's the same data in a pie chart instead of a bar graph that Dr. Russo showed earlier, comparing the mainstream treatment for fibromyalgia, which has neuropathic and inflammatory components, with cannabis. You see on the left, cannabis, 62% of the patients reported it as very effective. Only 5% said it didn't work. Compared to the accepted treatment, Cymbalta, 8% said it was very effective, while 60% said it didn't work. There's definitely something wrong there. But cannabis doesn't just treat the pain, it helps globally. It helps with sleep, depression, appetite, stress, and what I hear from my patients all the time is it helps their relationships. So I found this cartoon that I think emphasizes this. The woman's telling her chiropractor, the pain starts in my husband's lower back, then it travels up his spine to his neck, then it comes out his mouth and into my ears, and that's why I get these headaches. And it's really true that cannabis can in fact treat the whole family, even if only one person is using it. But what patients tend to say when they are using cannabis to treat their pain, they come back and they say, Doc, the pain is clearly less intense, but even more than that, it's less bothersome. The pain is still there, but I can get on with my day. I can play with my kids. I can laugh. I can get my work done. I can enjoy my life. And that's really huge. What we're talking about is the desirable outcome of improvement in function and improvement in quality of life. And that's always the goal when we're treating chronic pain. That's what we're looking for. We're not trying to disconnect someone from their body and make them so numb to their living experience that they don't even know what's going on. And of course, in the case of opioids or other drugs that are too strong for treating pain, a patient might take some of them and feel so good that they go out and mow the lawn, for example, or where I live, shovel snow. And then they get done with shoveling snow, they go back inside, the medicine wears off, and they say, oh my God, what did I do? I'm in big trouble here. So cannabis can treat pain. Now there's a huge body of evidence. This study looked at 11 randomized controlled trials, included with another review that was done. We've got 29 of these gold standard studies. 22 of the 29 have shown it's effective. That's why the federal government said, yes, this is a well-researched, there's conclusive evidence this is effective for pain. Now, what about opioids? Have they been proven to help chronic pain? I'm not sure how it is here in Cayman, but in the United States, this is the first line, maybe not the first line, but this is a standard and accepted treatment for chronic pain. It's just starting to fall out of favor because of all the problems that it's been causing. But here's a review article from 2015 that says the evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. And in fact, there's not been one study that's evaluated long-term outcomes related to pain, function, or quality of life. This entire practice in the United States of using opioids to treat chronic pain has no scientific basis, but we do know that it can create serious harm, like overdose, which is fatal, opioid abuse, fractures, myocardial infarction, and markers of sexual dysfunction, dysregulation of the sex hormones. So here's a study from one of our colleagues, Donald Abrams, where he had patients in the hospital who were already using opioids to treat pain, and they weren't getting good results, and they were allowed to vaporize a very, very low-quality cannabis that was supplied by the federal government 3 times a day, and they had a 27% reduction in their pain. There's been some recent studies that have looked at people with chronic pain, some of whom were using opioids, and they were given cannabis. This was an Israeli study. 73 of the 176 patients in the study were taking opioids. They were just given 20 grams of cannabis a month, and they got to choose if they wanted to smoke it, eat cannabis cookies, or take it by mouth in an olive oil extract or some combination. They were told to start low, go slow, and they were told to reduce your other medicines if you can. So this is not a very scientific or methodical prescription or titration schedule, but it still worked quite well. And 44% of the patients who were taking opioids at the beginning of this study were able to completely get off of their opioids after 7 months. This is pretty much unheard of in conventional medicine. As I mentioned, usually what happens is they come back asking and demanding more because the opioids are no longer working and they have worse pain. Another study from Michigan, again, it showed a 64% decrease in opioid use out of 244 patients with chronic pain. And we've looked at the data in Maine. We did the survey last year. We had 542 patients that were using opioids that added cannabis to their opioids. 39% of them were able to stop the opioids altogether, with 3/4 of them having been off opioids for over a year. This does not happen anywhere else in medicine. Trust me, my colleagues and I talk at the end of the day. We had another patient that stopped using opioids. It's just unbelievable, because this is the bane of the primary care providers' practice in Maine and in many of the states in the U.S., the people that are coming back asking for more and more opioids with no solution. Well, I'm so thankful that there is a solution. Another 39% were able to reduce their dose. And what's really important here is that 47% said they had this large reduction in their pain, more than 40% reduction in pain. And even most importantly, 80% said that by adding cannabis to the opioids, they had improved function, and 87% said it improved their quality of life. This is what we're after. This is compassionate treatment of patients. Now, this is such a huge problem in the United States. 44 people in the U.S. die every day from prescription painkiller overdose. These statistics do not include heroin. These are pills that doctors are prescribing. They're being filled by pharmacists, and they're killing 44 people every day. Every day, 7,000 people in the United States are treated in emergency departments for using prescribed opioids in a manner other than as directed. And 1 in 20 people in the United States aged 12 and over use an opioid non-medically. At least that's the statistics from 2010. It's probably gone up from there. So as you can see, this is a real epidemic that's killing people constantly, and the rates are just going up. We have prescription overdose on the left and heroin overdose on the right. You can see prescriptions are still a much bigger issue. But what happens is patients go to their doctor, they get some prescribed opioids, they come back, they say they need more, they get more, they come back later, they say they need more, they get more, and that process repeats until the doctor says, oh my God, I've got you on such a high dose, I can't give you any more. In fact, because you've got all these problems, I have to take away your opioids. I'm no longer going to prescribe that. Or even worse, they get a urine drug screen and they see, wow, you've been using a little bit of THC. That's it. You're out of my practice. Goodbye. I'm no longer prescribing for you. So then they go to the streets and they start buying oxycodone, which is quite expensive on the streets. And there's an alternative that's a lot cheaper. It's heroin, which has obviously a much narrower therapeutic window and a lot higher risk of overdose deaths, but it's affordable. So this is a problem that's starting in the doctor's office, and we're literally killing patients with this problem. Now, there's been a couple studies that have looked at using having cannabis laws and what effect that has on the population in general. These studies can't prove that there's a cause and effect relationship, but some of this evidence is quite compelling. So this is a father and daughter study from last year that looked at states that have a medical cannabis law and states that don't have a medical cannabis law. And what they found is that the states that have the law had significantly less prescribing of pain medications and of other medications. So you see the bar on the right, the red line, that's the level of prescribing that the states have without a cannabis law. And then as the bars move over to the left, that's showing how many fewer prescriptions. So on average, every doctor in the states that have a cannabis law are writing for 1,800 fewer doses of pain medications per year. Now that number sounds huge, right? 1,800 fewer doses per doctor just by being in a state that has medical cannabis. And this is only in Medicare, our national healthcare system for the disabled and the elderly. maybe the elderly is not the right word, and those young people that are over 65. Now, medical cannabis law and opioid abuse, another study that looked at various programs that have been designed to help prevent opioid abuse, programs like helping patients, or requiring pharmacists to get the ID of the patients before they dispense the medicine, or giving education to pain clinics, or increased state oversight and so forth. None of those programs made any difference, but the simple fact of having a medical cannabis law reduced overdose deaths by 25% almost. Again, this is very compelling. We have an epidemic and a great solution for it. This is a study from this year that showed that cannabis-using patients were using it to replace their pharmaceutical drugs. No big surprise there, and they have good reasons for doing so. It's safer, it's more effective, there's less addiction, less dependence, less withdrawal symptoms, and so forth. And so you can see the blue lines are opioid replacement, the orange lines are benzodiazepine replacement. Those are drugs like Valium, Ativan, clonazepam. And the gray line is antidepressants, yellow is other medications. So a lot of people are using cannabis to replace their pharmaceuticals, and they're getting better results. So there's just an image that kind of sums that up. There may be an alternative here. Now let's switch gears to cancer. We have a lot of interest in cancer here in Cayman, and obviously with Denny, and such great thanks to Denny for working so hard to pass this law here. We want to know what cannabis can do for cancer patients. So first of all, we know that it's a safe and effective treatment for cancer patients with nausea and vomiting, chronic pain, and insomnia. This is well documented. It's also been shown that cannabis can help patients tolerate conventional therapy that can be life-saving, therapies like chemotherapy and radiation. So a lot of times these therapies are limited because they're producing neuropathy in the patient, that's one of their side effects, or because they're producing nausea and vomiting, and the patient just can't take them, or other side effects as well. So cannabis can help them successfully undergo conventional treatment and potentially have better treatment success. And then, of course, for patients with terminal cancers, cannabis offers numerous benefits in palliative care at the end of life. Now, earlier I showed you some slides of cancer cell types in animals that have been treated with cannabinoids that have actually helped decrease the growth, and Dr. Russo showed those also. We're going to get there, but I wanted to also mention that in some of these animal studies that are looking at neuropathic pain, the very way in which the animals are given neuropathy, the animal model for testing neuropathic pain is to give them chemotherapy agents, because we know that these drugs are so good at producing neuropathy. And what's been shown in more than a few studies is that cannabinoids can not only treat the neuropathy, but it can prevent the development of neuropathy. So anyone that's undergoing cancer treatment with some of these very toxic chemotherapy agents would do well to take a neuroprotective agent, so that even if they do cure their cancer, they're not going to have to spend the rest of their life in neuropathic pain. And there's a lot of evidence that suggests cannabinoids can do that. So just a few more pictures to illustrate. Here's breast cancer on the left. These are the animals that were not treated. You can see the rate of growth. This is over 100 days, and that tumor grew along that curve over 100 days. In the middle, we have the animals treated with THC. The tumor still grew, but much more slowly. And on the right, a synthetic cannabinoid that had a similar result to THC. Another example, prostate cancer. We have lower growth in the group that received the synthetic cannabinoid. And what's really interesting is the ability for cannabis to work synergistically with conventional treatment. This is a study from 2011 on glioma, a type of brain cancer, and they tried no treatment, THC only, temozolomide or TMZ, the conventional chemotherapy agent for treating this cancer, and then they tried chemotherapy plus THC. And you can see the lines here, the line of tumor growth that's at the highest level, those were the untreated rodents. Down below we have the THC group. Below that we have the chemotherapy group. But hovering down there at the bottom with almost no growth, we have the combination of THC and the chemotherapy agent temozolomide. So there's great promise for synergy here. And I got asked at the break, wait, you're telling me that you believe in pharmaceutical treatments? And the person who asked me this really good question that I wanted to bring up to everyone who's here tonight was under the impression that patients have to choose between conventional treatment and cannabis, and that's certainly not the case. This is a decision that should be made on a case-by-case basis with a good understanding of the patient's diagnosis, their prognosis, their likelihood of responding to conventional treatment, and of course their personal preference, their spiritual preference, their ability to access cannabis. These are all factors that have to be put into a holistic decision. And often in my patients with cancer, I'll start off by treating with cannabis at a low dose to help alleviate their death anxiety so that they can get to the point of making good decisions, because so many people are so scared to die and so scared to suffer that they may not even have all the facts, and they often come to me with a poor understanding and unprepared to make a good decision about their treatment. Here's another study that just showed the combination of cannabis and radiation. So if we look at we can look at the 4 charts on the left. Top left, we have untreated. This is another type of brain cancer. Underneath the untreated group, we have the radiation group. No real difference there. In the top right, we have the cannabinoid group. You can see a little bit less growth of the tumor there, not a lot though. But on the bottom right, we have the radiation plus cannabis. And again, you can see almost no growth. Cannabis can be an excellent adjunct to conventional treatment in cancer. Now, there's a lot of patients that do end up using cannabinoid monotherapy. Sometimes that's because they're on a decidedly alternative path, and sometimes it's because the doctors send them home and say, sorry, we have nothing left to offer you. We hope that you can enjoy the rest of your life before you die. And that was the message that was told to this 1-year-old who had an optic pathway glioma. The patient went home, the parents started putting a concentrated THC oil on the pacifier, and if you look at the brain scans over the course of a little more than a year, the big white mass in the middle of the brain, that's the cancer, and you can see that mass just disappearing, and the patient is still alive with cannabis as the only treatment. If only the results were good in every single case like this. Trust me, they're not. But if you go on the internet and you read about Rick Simpson cure and all these other patients that are using cannabis, what you're going to hear about are the successful cases. You're not going to hear a lot about the unsuccessful cases. And so again, this is possible. I want you to know that this is possible and it will work for some people. But we don't know a lot about the optimal dosage, and we don't believe that it's going to work for everyone. Shifting gears here to epilepsy, just a quick summary of the paper that I recently published. Dr. Russo already mentioned it. A couple colleagues from Washington and California had a total of 272 patients with refractory epilepsy. Now, in the medical cannabis clinic, we don't get the easy cases of epilepsy, of course. We get the cases that have failed 6 to a dozen or sometimes more anti-epileptic drugs. They're coming to us as a last resort. We had incredible success with our patients using artisanal cannabis preparations. So in the pie chart, that little blue triangle that's sticking out, those were the cases that received no benefit. 14% of the most challenging seizure cases on the planet received no benefit from cannabis treatment. We had a small sector of these patients who actually got worse with cannabis treatment. But what this also means is that 86% of these incredibly challenging cases had some improvement. And I know it's probably too small for most of you to read the legend, but starting on the purple at the bottom, over to the bright blue and the orange, the purple is a greater than 50% reduction in seizures. The light blue on the left side is a 76 to 99% reduction, and that orange triangle, the 10%, that's complete seizure freedom. So more than 50% of our patients had a greater than 50% of reduction in seizures. This is just incredible results. And what's also interesting is that these results are achievable at an incredible wide range of doses. So effective total cannabinoid dose based on body weight went from 0.05 up to 9 milligrams per kilogram per day. That's a huge range. And so same with the blood levels of CBD in these patients, from very low to very high can be effective. Everyone's different. So the last part, I'm going to talk about the clinical dosing terminology. How do we approach this practically as clinicians and as patients to getting the right dose? Well, typically what we're talking about for dosage are the number of milligrams of the active constituents of cannabis, and usually we're referring to THC and CBD, which you heard Dr. Russo explain. These are the main components that are available now, and these are the heavy lifters of cannabis. All those other components are more like the fine-tuning. I use this analogy with my patients, but I think the younger ones have no idea what I'm talking about. Most of you probably know that the analog radios had the two tuning knobs, right? The big one and the fine-tuning knob. So we're going to start with the real tuning with how many milligrams of THC and CBD, and then things like which terpenoids, which chemovars or strains, and other components like that can really optimize the treatment. So I just go through some of the pictures here. We have on the bottom right the cannabis flower, which at the current time is not legal for medical use in cannabis. I hope and expect that at some time that'll change, because there's a variety of ways that people can use the bud. But there is a good law now that allows for cannabis oils. Pictured on the top, we have little bottles of cannabis oil in kind of a tincture bottle that can also be used as an alcohol-based tincture. But the oils work quite well, and you can dose based on the number of drops, or if you have to be very precise, you can draw it up in an oral syringe, which I have pictured next to the tincture bottle. And you can just squirt that in your mouth, hold it in your mouth for a minute or two. It'll start getting absorbed through the blood vessels in your mouth, and then if you swallow the rest, you'll absorb it through the GI tract. Now, the oral syringe filled with a cannabis oil infusion is different than what you see all the way over to the right, this dark tar-like material that's also tend to be stored in a syringe because it's so sticky and hard to work with. That's a cannabis concentrate, a very potent medicine that's typically responsible for overdose reactions. And again, overdose is unpleasant, but it's not toxic and not lethal. But just to give you an idea of how strong that black tar is, most of you in this audience, if you don't have a very high tolerance to cannabis, you could take a little smear of that tar about half the size of a rice grain. And if you did, you may have acute anxiety, paranoia, or even delirium, hallucinations. You may have nausea, vomiting, inability to sleep. It's quite unpleasant. So be very careful with that stuff, especially if it makes its way to the Cayman Islands. Now, on a different note, patients that have taken time to titrate up very slowly on their dosage to build a tolerance to the side effects, they can tolerate a rice grain or 5 or even 10 rice grains of that stuff with no adverse effects at all. And those are some of the doses that may be necessary in some patients to have anti-cancer effects. So dosing by the milligram, I mean, this is something that you do not see for any other type of medication. I put it here based on body weight, just to give you a frame of reference. I've seen such a wide, effective, and safe dosing range in my practice. What this means is, for someone my size, a 70-kilogram adult, I have patients that could respond to 1 milligram of cannabinoids per day. 1 milligram. Now, that's an outlier. Most people need more than that, but there are clearly patients that need just that much. And I've actually had one lady that needed less. She had multiple sclerosis. She smokes 1 puff of cannabis 2 or 3 times a week, and that's enough for her to have control of her bladder. It's almost hard to believe, but there are these outliers of people that are incredibly sensitive to cannabis, and they do well with very low doses. At the other end of that spectrum, we're not talking about 1 milligram, we're talking about 2,000 milligrams a day. Again, safe and effective. But even at that high dose, 2,000 milligrams per day or 30 milligrams per kilogram of body weight, that's still far below doses that researchers have given to try to kill monkeys. And trust me, in the late 70s and early 80s, researchers were doing a lot of work trying to kill animals with cannabinoids, and they really were unable to do it. Now, within this very broad dosing range, we have biphasic or nonlinear dose-response effects. This means that if you start cannabis at a low dose and you gradually increase your dose, you're probably going to notice more and more relief of your symptoms up until a certain point. And then beyond that certain point, as you increase the dose, patients tend to report less and less effects on their symptoms. And so with cannabis, more is not always more. And a lot of the patients that are already using cannabis that come into the clinic, they're in that red zone. They're taking a lot of it. They've realized that it's not working as well as it used to, and they ask me, how do I make it work better? Should I take more? And I say, well, actually, we're going to take a little break. You're going to take less. You're going to get back to your optimal dose, and you're going to have better efficacy with less side effects. And I have a specific protocol for doing that. Now, the optimal dose is different for every patient. It's based on our unique bodies and our unique internal environments. And this multiphasic dose response effect has been shown in rodents as well. This is a study that looked at their activity. How much are they running around? And on the very left, we have the gray bar. That's no THC was given, and that's their baseline activity. A very tiny amount of THC, 0.2 milligrams per kilogram, reduced their activity, so they stopped running around as much. As that dose went up, they started running around more and more. They were actually running around more than they were at baseline. And then as the dose went up even more, the activity level came down. But it didn't come down as far as it went at that very early, tiny little dose that they were getting. And what did happen after they passed that peak there, and you can see on the top bar the emergence of something called catalepsy. That's in rodents what Ethan was describing as couch lock, remaining still in an unusual position. Typically they use a bar test where it's kind of like the mouse is going over a hurdle and just forgets what it was doing and rests there. Not a dangerous side effect, but not necessarily desirable. So my point with this slide is that sometimes these very low doses can achieve better results than high doses with less side effects. And again, this has been demonstrated in humans. This is nabiximols or Sativex, the pharmaceutical-grade cannabis combination that Dr. Russo was talking about. A study done in patients with chronic pain that were already using opioids. And what this graph shows, the baseline at the top is their pain level. On the left, we have placebo. This is really impressive, right? You give someone a sugar pill or an empty spray, and their pain goes down. Now, it has been shown that part of the physiology of the placebo effect is mediated by our body's own cannabinoids. So even if I don't give you any THC or CBD in that spray, just by spraying it and believing that it may help you can actually activate the cannabinoid system and create a reduction in pain. But even more than that, the 20 milligram group had this big reduction in pain. The 50 milligram group had a less significant or less powerful reduction in pain, and the 80 milligram group didn't really do much better than placebo. So again, remember with cannabis, less can be more. So new people that are new to cannabis, what do I tell them? I tell them, number one, start subtherapeutic. That means if you have someone that's new to cannabis, they have a higher likelihood of experiencing the adverse effects. And I would like for them to avoid that, because if they do get the adverse effects, they might say this medicine isn't for me and they no longer give it a chance. So I say to my patients, bear with me. I'm going to start you at a dose that's so low you're probably not going to feel anything. Some patients do feel it at this dose, but we're just going to start there. Then you very slowly increase it until they feel a little bit. Now, they're not experiencing the full power of cannabis, they're just feeling a little bit. But if they hang out at that dose for a few days, what they're going to do is develop a tolerance to the side effects even before they have them. They're going to have a wider therapeutic window to go through later in their treatment. And then in some cases, they're also becoming more sensitive to cannabis during those 3 days. And that same little dose that barely did anything on day 3 actually has a stronger effect. But then on day 4, go right ahead and start gradually titrating up again, increase your dose, and you can achieve a good result. Now here I have pictured my father, who's in the front row, along with my grandmother, Elaine Sulak. This picture was taken on her 91st birthday. She passed away last year, but my grandmother was treated with cannabis tincture for the last 8 years of her life. She had fibromyalgia, she had a hip fracture, she had a lot of arthritis, and a lot of pain. She never knew what she was getting. We never told her that it was cannabis or marijuana. I don't even know if she would have understood the word cannabis. To her, it was the herbal pain tincture. and it worked incredibly well. It allowed her to get off of other medications, but even more than that, it improved the quality of her life. It really relieved her suffering, and I got to see my real grandma come out. She became happier and funnier and more loving and more affectionate, and just in general, the better her in every way was able to emerge, because as you can imagine, when someone's in pain and not sleeping well and dealing with all these symptoms, it's really hard for them to be their kind, loving self. So it was just such a gift to my grandma, and I think it has a real role for our elderly population, and we owe it to them to offer them this medicine. So nuts and bolts, cannabis-naive patients, those that haven't tried it before, what am I talking about as a starting dose? Literally 1 or 2 milligrams only, 3 times a day if you're taking it by mouth. That's what I would recommend. If you have access here to CBD, and I hope that does come to Cayman soon, like nabiximols or Sativex, this 1-to-1 ratio, equal parts of THC and CBD, that's broadly effective and well tolerated for a lot of people. Track and document their response, and then I often recommend other activities to kind of potentiate this. Get them using cannabis and exercising or meditating or doing yoga or prayer or whatever it is that helps them. Now, if you're a patient that's using just THC and you start adding CBD in, you'll notice that the overall number of milligrams that you have to take goes up. Again, this is because, as Dr. Russo mentioned, CBD can block some of the activity of THC at those cannabinoid receptors. So you'll need a higher overall dosage, but what you'll also get is a better overall medical effect with less side effects. So it can be a bit more expensive or resource intensive to treat people with both THC and CBD, but it's certainly worth doing. Now, there's a lot of patients that are thinking that it's, and this may be based on some of the CNN episodes that I referred to before, thinking that CBD is the medical part of cannabis, but THC is the recreational part of cannabis. So if I have symptoms, I'm just going to use CBD. That was a myth that kind of came out into our culture at that time. And that is clearly not the case, which you've learned tonight. But the patients that are trying to treat their conditions with CBD alone, especially these hemp-based CBD products that are now available all over the United States, technically they're illegal, but they're being shipped across all the states. Nobody's getting in trouble for it. They're marketed as hemp products. Well, if you're going to do that, you're going to need a lot. You're going to need probably more than 2 to 5 times the dose of CBD milligram per milligram than you would need of just the THC alone. Now, there's some speculation, as Dr. Russo mentioned, that higher doses of CBD can be sedating. I haven't seen that in my clinical practice, and it's probably not related to the CBD, probably more related to the myrcene or the other components. But low doses of CBD can be stimulating, mentally alerting and stimulating. Patients report that when they add in the CBD, they have more clarity of mind and more alertness, which is really nice. CBD can also be used in extraordinarily high doses, 1 to 500 milligrams per dose for certain conditions, for example, psychosis or schizophrenia. And this is just a chart that's showing that comparing patients that were using THC only to patients that were using THC plus CBD, the THC plus CBD group needed more than twice the number of milligrams per day to get the results, but of course they had much fewer side effects. Now, a lot of patients are coming in, and this kind of surprised me. They say, "Doc, I've used cannabis, it helps with my symptoms, but I don't want to get high." And it makes sense to me now, but when I first started, my first few months of doing this type of medicine, it was strange to me. I thought getting high is possibly what they were looking for, because that's the thing that was alleviating their suffering. But it's clearly not. These are real symptomatic relief that people are experiencing, real medical effects. And so these are some strategies that patients can use to not get high when using cannabis. And even if they don't have access to CBD, they can still do that with just THC using the method I described. Low-dose THC after taking a few days to allow that therapeutic window to widen. So again, starting very low, going to a minimal effect, staying there for a while, and then titrating up very slowly. So I might have a patient that has a tincture or an oil. He knows how strong it is. He might know, I can take 5 drops of this stuff before I go to work. It's going to help me with my pain. It's not going to impair me at all. I'm still going to be sharp and productive. But if I'm having a really bad day and I stay home from work, or if it's the weekend, or if it's before bed, I'll take 8 drops, or I'll take 10 drops, and then I'll get some of that euphoria or that psychoactive effect. And that's perfect. Patients can self-modulate that and choose to have a psychoactive effect when they want. Of course, using higher ratios of CBD to THC, especially in the patients that are very sensitive to THC, once you get above that 3-to-1 or 4-to-1 ratio, it can be quite hard to get any intoxication or impairment for the THC. You'd really have to overdo it. The acidic or raw cannabinoids, as Dr. Russo mentioned, so for example, cannabis tea, which is used widely in Jamaica, cannabis tea is not likely to get you high, but it could have some of these anti-inflammatory and other health benefits from the THCA, the raw form of THC. And then, of course, topical delivery, which hasn't been mentioned yet, but if you're, say, just treating an arthritic knee, you don't have to take it by mouth or inhale it to treat that knee. You can apply cannabis oil directly to the joint and let it soak into those tissues for an anti-pain and anti-inflammatory effect. And this is a delivery route that I use a lot with elderly patients that's incredibly effective. Now, let me back up for a second, because I want to point out that while a lot of patients don't want the impairment or they don't want to get high with cannabis, there's still real healing value to that experience. The shift in consciousness that accompanies the THC effect can be extraordinarily therapeutic to patients. Patients report that during that state of consciousness, they can suddenly feel more connected to things around them, like nature or God or their family, that they can come up with creative solutions to problems in their life that they didn't have a solution for before they entered that state of consciousness, or that they can have an enhanced enjoyment of pleasurable activities in life that they have no longer been able to enjoy. You know, these types of realizations, they last longer than the acute effects of THC. The medicine wears off, but this profound insight into one's own self, one's own problems, a deeper relationship with self, or a feeling of connection to Great Spirit, those are powerful healing agents that will last much longer than the effects of the drug. And so I do encourage all of my patients, or not all, but most, when the time and place is right and the environment is right, to have a mild cannabis psychoactive experience. Now, for experienced users, well, as I mentioned before, most of them come in using too much. We reduce their dose to get greater efficacy. And on healer.com, I have a specific 6-day protocol for doing so. It includes 2 days of cannabis abstinence, followed by 3 days of careful titration. And on the 6th day, go right ahead and use as much as you want. I took a survey of 48 patients who were smokers. They had used this protocol. They reduced their dose by more than 50%, 56% reduction on average, all with equal or better medical effects. So this means they're using less, they're sparing their lungs, they're making more cannabis available for the next patient because they're not wasting it, they're getting better results and less side effects. Now, Ethan went through some of the chemovars and strains. These are this is a topic where people get caught up a lot, and I encourage you, please don't pay too much attention to the terms sativa and indica. They're almost always misused. Typically, sativa plants give more of an energetic or high, whereas indica effects give more of a sedating, stoned type of description. But what you see in dispensaries in the United States, they're all mixed up, and these terms are really irrelevant. So I don't think they have much clinical value. What's really important clinically is not whether it's called power plant or phaser or big bang. What's important is the ratio of CBD to THC, if people describe it as stimulating or sedating, and of course, patient-specific responses. If and when you have the variety and the analytics to look at the terpene profile and see, wow, this one has alpha-pinene or this one has linalool in it, then that's great. You can use that to help you select your strain. But until you have that, you have a great piece of equipment that can already detect all of those terpenes, and you can become very familiar with them. It's your nose. Your olfactory sense is highly developed, and if you have a cannabis bud that smells like lavender, it's probably got linalool in it, and it's probably going to be good for nighttime daytime use. It'll probably be good for muscle relaxation and for seizures. And if you have a cannabis bud that smells like pine, it's because it has that pinene in it, the same molecule you find in pine needles, and that might be a better strain for daytime use. And I just put these 3 slides up there to show you that you cannot judge cannabis by how it looks. It's much better to use how it feels and how it smells. So this is a THC-dominant cannabis flower. In the middle here we have a cannabis flower that Ethan would call a type 2, kind of balanced levels of THC and CBD. And over here we have a CBD-dominant plant that almost has no THC in it at all. And you can clearly see that they look almost identical. So we're going to just quickly go through delivery methods because Dr. Russo did most of that already. But inhalation, the benefit of inhalation is the rapid onset. It kicks in right away. And so if you have something that's happening right away and you need that effect, inhalation is the best thing for it. Examples in my practice, I think migraine, for example, I have numerous migraineurs who report that if they use cannabis very quickly at the beginning of the migraine, they're able to abort the episode or put a ceiling on the pain level and it never gets full blown. But if they wait too long, then they can't control the migraine, and some patients actually report that if they wait too long and they try using cannabis, it'll make the migraine worse. So in those situations, I would want my patient to use a very rapid delivery method to get it into them. The same might be true for acute psychiatric events like a panic attack or an impending panic attack, or someone that's been exposed to a trigger for their post-traumatic stress disorder and needs to settle down quickly. Inhalation could work well, but as I mentioned, it's probably not the ideal for pain and other chronic conditions that a patient's dealing with all day and every day. Now, pictured on the bottom right here, that's one of those vapor pens that Dr. Russo was describing. There's potential for cannabis oil to be imported into Cayman under the existing law and used in a vaporization apparatus if it's used correctly. Again, too high of a temperature and now you're causing carcinogens. A solvent to cut the material could be causing formaldehyde formation and other carcinogens. So while this is possible, it's going to require a lot of attention from the pharmacies that are dispensing it to be done right. And hopefully people like Dr. Russo and I will be able to lend our help to them so that they are able to do it right. In the top right and the middle on the bottom, these are vaporizers that don't use extracted oils, they use the whole flower. So it's basically, instead of putting the flower in a pipe or in a joint or spliff, you put it in this machine that has a little oven in it. It heats it up to a certain temperature where the oil evaporates and you can breathe it in, but the plant matter does not combust. Now, the oral mucosal or enteral, through the mouth or through the gut, absorption is going to be the best, the most broadly effective and well tolerated. As sprays, drops, and so forth, very, very good form of cannabis as a medicine. Capsules, like in the top left, that's dronabinol, which is a synthetic THC capsule. Not ideal because it takes a long time to kick in, can be up to 2 hours. The absorption can be very erratic, so one day 5 milligrams might do a lot for you, the next day 5 milligrams might not do anything, or one day 5 milligrams might be perfect, but the next day 5 milligrams might cause a lot of impairment. It can just change from time to time. And also then there's the cannabis treats. Not my favorite method of delivering a medicine. I think medicines shouldn't be delicious and appealing. I think they should be medicines. Cannabis-infused coconut oil came across our radar. This is very likely going to be the first type of cannabis that's available here in Cayman. And so I just wanted to finish up here by showing some numbers of what this might look like. If somebody takes cannabis flowers and puts it in a slow cooker with coconut oil, what you end up with is something that might look like the bottom two, the left two pictures, right? A cannabis oil that then could be put in a standard dropper bottle, and you could use a certain number of drops, or a graduated dropper where you can know how many milliliters you're getting. Now, if you're in Maine and you make a cannabis coconut oil, it's not going to look like those pictures on the left. It's going to look like that jar there, because room temperature at Maine almost all year long is about 68 degrees, depending on where you put your thermostat, but coconut oil gets hard at those temperatures. But nevertheless, it can be used to put inside a capsule or other preparation as well. So if you had a coconut oil extraction that was 1% THC by weight, that means you'd have roughly 10 milligrams in each milliliter of the oil. A standard dropper is 20 drops per ml. So again, my starting dose, recommending 1 to 2 milligrams. We're talking 2 to 4 drops of that oil. Hopefully whatever does come to Cayman will have a known potency, and you can do these calculations precisely. Most patients do well with 2 to 10 milligrams 3 times daily for symptom relief, but as I mentioned, there's outliers, and some patients are going to need hundreds, maybe even thousands of milligrams. All these patient education strategies that I mentioned tonight are in great detail on healer.com, along with my favorite exercises and meditations to combine with your cannabis treatment, so please check it out. If you have a doctor that's interested, I have a document. It's just 3 or 4 pages with references on there. You can print this up and bring it into your doctor, and it gives them the very most basic, important clinical information they need to know for patients that are using or considering using cannabis. And then I just finally wanted to give a plug to the Society of Cannabis Clinicians. This is a professional organization for clinicians like myself that are using cannabis with their patients. A lot of us feel estranged or out there in the world without support when we first get started. It doesn't have to be that way. Connect with other clinicians all over the world that are doing this type of work, and we can share cases and share education and information to push this field forward. This is truly an emerging field of medicine. Just like we have specialists in neurology and gastroenterology, we now have specialists in cannabinoid medicine, and we're the ones that people are sending their patients to, the patients that don't respond to anything else. And often we get great results. It's not because we're such great doctors, it's because we have a great medicine to work with. So thank you so much. It's been a pleasure to be here to present to all of you tonight. Really, I'm so grateful for the opportunity.